Hello, my name is Thompson, and I am a MPH candidate. Before I get started, I would like to thank and acknowledge the Algonquin, Songhees, Esquimalt, and Sandwich peoples for having me on their land for this presentation today. I completed my MPH practicum internationally in Misungwi, which is located in the Mwanza region of the United Republic of Tanzania. As a student, my role was to develop and implement a 3-day professional development workshop on gender-responsive, respectful, and dignified maternal care. I worked very closely with the Mtoto field manager and their gender and equity coordinator. The Mtoto project is largely community-driven. As you can see from the slide, some of the local partners include the Catholic University of Allied Health and Sciences, which is located at the Bugando Hospital in Mwanza City, as well as, of course, the regional and district health management teams. The community-identified social health issue was the prevalence of gender inequality and the delivery of disrespectful maternal care, understanding that these social influences may contribute to the region's high maternal death rate. In Tanzania, each year, almost 8,000 women died due to pregnancy and delivery complications, the day of birth being the most dangerous for mothers, resulting in over 40% of the maternal death. What is perhaps most unjust and considered both a gender and a development issue is that almost 70% of these maternal deaths occur from preventable causes. The project found that women were not accessing services at the rural government-funded health facilities due to a number of complex and multifaceted reasons, one of which, relating to gender, is that women are widely understood to have a subordinate status in comparison to men. This gender power imbalance leads women to have little autonomy, empowerment, and decision-making control at the household, community, and health system level. Thus, women are often unable to advocate for or individually act on their maternal health needs. Furthermore, it was found in past studies in Tanzania that women expressed experiencing lack of privacy due to poor infrastructure of the health centers and lack of available resources, and disrespect from care providers during labor and delivery for many complex reasons. These are only just a few examples of barriers to equitable health services and reasons why women were delivering at home and without the presence of a skilled birth attendant, putting them at increased risk. Before diving into workshop planning, it was important that I completed a literature synthesis to better understand the subject matter. I utilized only peer-reviewed, current, scholarly full-text articles published in the English language and within the past 5 years. I wanted to answer the question, how can the health system and how can health facilities become more gender responsive? The findings from my literature synthesis helped inform the program development. Overall, the workshop was intended to raise awareness of gender inequality issues affecting local girls, women, and families, equip local health leaders with materials and tools to become more gender responsive, and promote facility capacity building and positive sustainable change. In the workshop planning stages, in effort to be consistent with the Mtoto program development, I created a logic model and utilized the Sopatar strategic cycle, pictured in the top left corner of this slide. The workshop content and layout recognize self-determination theory as an underlying methodology to promote adult learning. The workshop invited local health leaders ranging from facility nursing staff, in-charges, pharmacists at the local dispensaries, and members of the community health management team and more. The workshop utilized a volunteer participatory engagement approach, which recognized that the participants were, of course, the experts in both their facilities and their communities. The workshop was strategically split up into 3 different days. The content of the first day was meant to raise awareness of key gender definitions and increase the participants' understanding of gender as a determinant of health. We discussed gender identity, roles and relations, the difference between equity and equality, and how these relate to maternal health outcomes. We talked about the importance of girl and women empowerment and what positive effects may result from engaging boys and men in both gender advocacy work, and also in maternal care. The second day took the previous day's key themes and applied them to the health system context at the facility level. We discussed professional codes of conduct, what it means to provide dignified care, the importance of self-care as any service provider, and gender mainstreaming strategies. Workshop activities range from moments for critical reflection on an individual level to group empathy building exercises such as the World Health Organization's Gender Mainstreaming Power Walk activity. The third and final day focused on individual facility action planning. Creating an action plan for each specific participating facility recognized that each health center is entirely unique, especially pertaining to its strengths and weaknesses in services delivery, its infrastructure, and its access to available resources. As with any workshop, it was important to understand what was done both well and maybe not so well, so I created an informal and anonymous participant feedback form. The feedback form consisted of 2 parts and was completed at the end of day 3. The form was distributed in English, but was translated into Kiswahili by the facilitator at the time of its completion. The first part of the form utilized a 5-point Likert scale and asked participants to rate workshop components on a scale from strongly disagree to strongly agree. These 6 statements for rating are stated on this current slide. The second half of the form was short answer format, and participants were asked to share their favorite parts of the workshop, their least favorite parts, any opinions on what they feel should have been expanded on or excluded, and just any additional comments they wish to share with the facilitators. From my observation, overall it seemed the workshop received positive feedback. I believe the highest rated components would be the language used and the organization and flow of its activities. The somewhat disagree and neutral responses are to reflect the limited workshop printed materials for participant reference that we had available at the time of the workshop. Unfortunately, there were some logistical barriers that prevented the amount of printed resources we could have on hand, such as a power outage on the first day of our workshop. Any constructive feedback, however, was taken into account for all of the post-workshop gender program development. Some of the identified project strengths include the use of multiple workshop facilitators, all of whom were community selected and were local health professionals in the Mwanza region. Another was that the program developers worked in very close partnership with the workshop participants to support community ownership of the gender responsive action plans, not only at the time of the workshop, but also in our program development after the workshop. Lastly, the workshop content and materials recognized a gender in teaching learning continuum. Although the agenda was comprehensive and ambitious, ultimately we aim to engage participants in gender transformative discussions while recognizing the local deep-rooted socio-cultural values and beliefs regarding gender. One of the most challenging aspects of the workshop was apparent during the participant action planning. Taking such a broad and subjective topic and narrowing in on a specific objective to create a measurable and actionable action plan was very challenging. This was especially so because we were having to target low-hanging fruits due to budget constraints and limited access to available resources. Key future recommendations would be to encourage earlier communication with the selected workshop facilitators and earlier distribution of the workshop invitation letters. Another would be to disseminate gender equality training to the community health workers as they are in a key position to support women and families in accessing services in community. In an effort to leave no girl or woman behind, there is continued need to improve equitable access to essential maternal health services, especially for those residing in rural areas. In order to continue working towards the Sustainable Development Goals for the year 2030, gender advocacy work must continue to focus on girls and women empowerment, engaging boys and men, and demanding gender-responsive accountability and transparency from health and social policies across all jurisdictions. Some key take-home messages are that working in partnership with community health leaders for gender equality program development helped establish a shared vision, increased awareness on a poorly understood topic, and a sustainable plan for gender-responsive facility capacity building. I would like to acknowledge my UVic instructors, Nigel Livingston and Kathy Worthington, my practicum supervisor, Tanya Saluski, and Helen Mahadini, the Gender and Equity Coordinator for Mtoto. Without all of them, my graduate practicum would not have been possible. I would also like to sincerely thank Dr. Charmaine Enns for introducing me to the Mtoto project, and for my family and friends who provided endless support as I completed my degree. And if anyone would like to contact me, I have my contact details on the slide there.
Questions for Caitlin?
Oh.
Really amazing practicum. Thank you for sharing it. I'm just curious, the participants for the workshops, do they have many opportunities to participate in workshops? Like, was it a kind of a new concept? And is there any plans for sort of a follow-up so they can come back together and share how their action plans went?
Yeah, really good question. They had participated with previous workshops, like with the Mtoto project, but this was a fairly new one, like in regards to the gender equality development. It sounds like the program had a really hard time getting their gender program development off the ground. So this was kind of a newer thing for them. All of the participants, though, were like local health professionals, and all of the participants that were invited, or not invited, but selected to attend were chosen by the community. And yes, in regards to the action planning, a part of my project was also doing post-workshop follow-up. So we actually had 2 facilitator meetings, both for the Misungwi and Quimba districts, where we planned to make a schedule with the community-identified gender experts, and then provide mentorship visits to all of the participating facilities for action planning follow-up. And we actually had, when I was there, we were able to complete all of the ones throughout the Misungwi district. Unfortunately, I had to come back here for this, so I missed the Quimba ones. But yeah, so at those first health facility visits, they were quite actually structured, and not only was it like members and the in-charges and facility staff at the participating center, but also we engaged the community. So we had like local, the tribal council members, and then also like the community health coordinator, community health workers, and even local religious leaders that were community identified, and invited them to join the discussion and to learn about what the workshop shared, and then also what the facility is planning to do to become more mother-friendly. Yeah.
Other questions for Caitlin? While I'm walking the mic over, how long has the program, the overarching program, been in operation?
Well, it's actually entering into its final year, so I believe it's like a 5-year project, and the field activities end at the end of this year, and then it'll be running like an evaluation process until 2020. Yeah.
Thank you for sharing the information. What barriers do these healthcare providers face with this new knowledge that they have? So if they're going upstream against a massive cultural shift or barriers, how are they dealing with that? And are they getting, you said that there was continued support, so what does that look like in this term? And what is the long-term impact? You kind of answered some of this, so I'm just going to go through my questions of the uptake of the info. And then Meg's question is the program repeatable in different communities? Okay.
Yeah, so first question was on, like, not upstream, but how is it like a collaborative approach, I believe?
So people now have this knowledge, and maybe they want to make a change. But if the culture around them is still toxic or still not changing, how are they facing the support as individuals?
Yeah, and I think that was why it was so important, and like that, well, this whole action plan is community owned, and that also we engage like so many different members of like the district council teams, the regional like community health management teams, like the local health, but the local religious leaders, because they have like a major influence on like thought processing and like just even gender roles and relations as well, and like to help raise awareness. And then also like the community health workers, because they're the ones that like are actually out in the community in these very remote locations, working hand in hand with families and women when they're trying to access services, and maybe meeting all sorts of barriers, such as like really long travel distances to like just like having little money to travel. So I think that was one of the strengths, was that we really tried to make it a collaborative process with sort of like all different sectors of the health governance there. And then, yeah, part of it was engaging, so the nursing, the facility staff, the pharmacists, but also the in-charges and the district health leaders. So then there was like also a level of accountability for that as well. And acknowledging too that like anybody that works in the healthcare field knows that it's a very challenging job that's very high stress. Awful things can come from like errors, medical errors, especially in these remote communities. People are often working understaffed, under-resourced. So it's a very, very complex issue, but that's why I think having like the support of the entire team was really important. Have everyone, yeah, having this shared vision together.
Thank you, Caitlin. Great answers to the questions. And thank you again. I think we're going to switch it up. So thank you, Caitlin.
Okay, thank you.
And